since COVID.
Well, hello, everyone, and welcome to Health Hour Live. My name is Leslie McGill, and I have the honor of leading the fantastic team here at Medical Alert. Today, we are speaking about a part of the healthcare system that has had relatively minor or low visibility, perhaps, to many Canadians until about a year ago. And in fact, tomorrow marks a pretty stark anniversary in Ontario. Tomorrow is the 1-year anniversary of the day that the Premier called the military to provide emergency help to 2 long-term care facilities here in this province. And a few weeks later, we saw the same thing happen in Quebec. So that's not necessarily an anniversary we want to celebrate. So today, while individuals and caregivers in long-term care have been vaccinated for the most part, we are still facing some pretty gaping wounds in what we seemingly uncovered in the past 12 months. And I say seemingly uncovered because for the past 30 years, our Health Hour Live guests have been researching long-term care and its many challenges. So I'm not necessarily sure that the gaping wounds weren't necessarily recognized before the last year. So today, I would like to welcome Drs. Pat Armstrong and Jacqueline Chouinière. Dr. Armstrong is a distinguished professor of sociology at York University and the principal investigator of the Reimagining Project, which was a 7-year multi-country study focusing on approaches to care, work organization, accountability, as well as finance and ownership in the long-term care sector. And Pat's work has evolved into several other related studies, more recently launched, such as the COVID-19, families and long-term care, residential care. And as I said, joining Pat is her co-investigator, Jacqueline Chouinière, an associate professor of nursing and environmental studies, also from York. Jackie's research has focused on the influence of political, economic, and social forces on the quality of care and the quality of work and life for nurses and other healthcare providers. So welcome to Medical Alert's Health Hour Live, Pat and Jackie. We are delighted to have you here today.
Thank you.
Thank you very much.
So I want to begin with setting the stage for our discussion today. And to have you tell me a little bit about your research work and what interested you in the particular area of study around long-term care.
Well, we actually moved from hospitals to home care to long-term care over this period in time. And for me, it started as an interest in women's work, which is what I did my thesis on a million years ago. And it's still at the very center of what we do. But it is also about how we are very interested in making things as good as they can be. And this was certainly an area where there was lots of opportunity to figure out better ways of doing.
So Jackie, so speaking of figuring out better ways of doing, walk our audience through a little bit about how we got to the state we are in now. And I know that's probably a long story, but tell us what you've seen over the course of your years researching this particular field.
Well, certainly, and keeping in mind, I am a registered nurse, so my view started from the inside, so to speak, and it was I felt certainly experienced issues that were important enough that is a large reason why I returned to school and became really interested in health policy and met Pat and our history unfolded, as it were. But yes, we certainly our study, the one that you mentioned, Reimagining Long-Term Care, international study of promising practices. In that study, the great majority of which was completed prior to COVID, we laid out all sorts of problems and potential solutions. And these issues have to do with staffing, and not only the numbers, but certainly the numbers issues, because there was the issue also of the importance of full-time. we learned and talked about then that care is a relationship. We needed to think about care as a relationship. And so staff and the older adults required time in order to build those relationships. So staff could assist as best they could. They needed to know the individual resident and develop that relationship, because that made such a difference. The other piece that struck us very early on in our research was that long-term residential care is both complex care, but it's also the senior's home. So there are both parts of this very important relationship, as it were, that needed to be emphasized, that we really needed to pay attention to.
So I probably should have provided a bit more background about the long study that Jackie was referencing, which actually went on for 10 years. It was initially funded for 7. And we just wound it up a year ago before we started these other studies. But in addition to looking at things like overall staffing levels and the kinds of overall issues that you can get from survey research and studying policy, et cetera, that we did, at the core of our research in these 6 countries, which were Norway, Sweden, Germany, the UK, the US, and Canada, in each of those countries, which took a team of 10 to 12 people into a home over the course of a week, starting at 9 o'clock in the morning, going through past midnight, sometimes overnight, working in shifts and in teams to observe, to interview, to really get into the daily living that Jackie was talking about. And so when we're exploring the areas that Jackie just identified, it was through these multiple kinds of methods. And I should also say, unusually for academic research projects like this, the people who went into these homes were mainly staff and were mainly faculty, sorry. And most of those faculty were actually seniors. So most often the students go out and do that kind of primary data collection and under the guidance of professors, but we were actually doing the nitty-gritty work, which I think also made a difference with students. There were also always students involved, but it gave it a very different component, I think, in terms of not just being able to show some data in these areas like staffing that Jackie identified, but what that really means on a daily basis for all of those people who are there. And one of the things I would add to Jackie's list is that is connected to the last point she made about these being places to live, is we really recognize the importance of food, of laundry, of housekeeping, in terms of providing care and in terms of being essential parts of the team. And in fact, we ended up writing a book called Wash, Wear, and Care because of what came out of our research in terms of this being such a crucial component in being treated with dignity and respect.
It must have been a visceral experience to actually spend time, a 24-hour period, whatever it may happen to have been. Talk about that, because so many of us have not had that opportunity to set foot in a long-term care facility for any length of time. We may have gone as a visitor and spent a small window of time, or we may have never been in that context. But when you really get in and understand, it speaks to something, as we were preparing for this session, that really struck me, and perhaps you can comment on this as well, which is the context of the level of work is the level of care. It's a phrase that you use quite often. And so if you can correlate those two things, that visceral experience that you have and that outcome statement that you made, please help the audience to understand what that actually means.
Before I hand it over to Jackie, our phrase is really that the conditions of work are the conditions of care. And we would, and part of that came out with there was a whole movement to say it should be resident-centered care. And they forgot about those conditions that Jackie talked about. If you don't have those conditions, you can't focus on the resident. And it certainly was a visceral experience. In one of the books we wrote about this, some of the students described what it was like to have that experience, to be immersed on a daily basis. But it was also an experience for many of our faculty. Half of the people involved in this project had never worked in long-term, had never done research on long-term care, which we did purposely because we wanted to bring what we called fresh eyes. The other way we brought fresh eyes is every one of these teams was international and interdisciplinary. So we have 4 physicians, for instance, on our team. And for some of them, actually going in and sitting in a long-term care experience was brand new. And that was also the case for our epidemiologist, who had done masses of data analysis on long-term care, but he never actually sat down and watched how the data were produced.
So before you jump in, Jackie, that poses a really interesting question to me, which is that part of the reason why we are where we are today? Is we've got these external forces and data collection going on, but no, or less than optimal perhaps, experience, literally lived experience informing policy decisions and operational decisions. I'm curious about that.
Well, yes. Yes, I would say that is one reason. And I want to emphasize something that Pat said about the just this different eyes approach. I had the privilege of working, one of my partners in a couple of the homes that we visited was an historian. And in fact, we wrote an article entitled Different Eyes, and what that meant when there was a nurse, sociologist, me, observing with an historian, and we were seeing such different things. I was there. I was initially looking at, because of the past, because of my initial interest, I was looking at what are the relationships going on between staff, among staff, with staff and family, with family and staff, and this was my focus. And my colleague, he was looking at the historical nature. He was noticing things that were, because he had done a lot of work about the start of nursing homes, the historical start of nursing homes. I'm sorry, Pat, the poorhouse.
Yes.
The poorhouse. And so he was seeing all of these strains of the past and what that meant and how that was brought forward. And just that factor. Oh, and I wanted to say, our colleagues from Europe who had, especially England, who had not been into a nursing home the size of the ones we were in, she was, her reaction really assisted us in a different level of analysis as well, seeing through her eyes what she was seeing and what her expectations were. So yes, I would say that. I would also say there has been a focus through what we consider to be our accountability assurances in long-term care. There's been a focus on clinical issues. And I am not at all one to say we could ignore clinical issues. Clearly we cannot. But this goes back to quality of life issues as well. If we ignore the context, the social context, what these individuals need in their homes, then we are not going to do what we need to do to assist them around the clinical issues either.
So
well, and Jackie has paid a lot of attention to this other aspect of that, is that we think we know what's going on in a long-term care home by counting what can be counted, which is another phrase we like to use a lot. And those things that tend to be counted are clinical, and they don't necessarily assess the quality of life. They certainly don't capture what brings you joy. So we've written a lot about this question about how do you make these places accountable, and Jackie can can certainly talk a lot more about that, because she was the chair of the section that did accountability
Accountability.
and governance issues. So, but those are very important. And when you think that, to go back to where the question you asked, we have certainly encountered people who are making decisions about these places who have never been in one, and certainly haven't been in one for any length of time. And it makes such a difference if you spend a long time in one.
No doubt. I have absolutely no doubt. I have not spent a long time. I've had the experience, and it was, I probably reacted very much like the students did, which is, this is not what I was expecting I would see. There are many patients with complex care needs, and facilities that, you know, I wouldn't want my grandmother to be a part of. It's a challenging and sometimes heartbreaking thing to see, in some circumstances. So my next
Well,
question really leads me to.
Can I just
Of
add
course.
something to that? Because the other thing is that when you stay longer, you get a different perspective on it. So when we first went in, and the students talk about this as well, you hear someone saying, "Mom, nurse, nurse, nurse," and you think, "Ah, these nurses are never answering her. It's terrible. They're not providing care." And then you learn that this is something this woman does, that they deal with her respectfully, but this is her particular issue, right? And we often found ourselves running to assist someone, and then realizing, first of all, we didn't have the skills. Now, Jackie, not so much, but I didn't have those skills. But also that because we didn't know the resident, we didn't know how they were dealing with that resident, that we would initially interpret it as neglect or inappropriate behavior. And that too is really, really important, because if you just go in for a short period of time, the last thing I would say about, no, it's never the last thing I say, but anyway, the thing, it's really struck me when so many people were astonished in Ontario that we had 4-bed rooms.
Mhm.
They clearly hadn't been in homes in Ontario.
Yeah.
Exactly. So that's an interesting perspective, because you're right. You were talking about relational care and a relational care model that is dependent upon the resident in the facility and the providers and the care providers who are there to understand needs. So my next question really is, and it may not be a fair question, but I'm going to ask it anyway, which is, if you were to effectively pick the sort of the 3 most significant holes in the long-term care system in this country that appeared before COVID, that were so self-evident in your research. I know it's probably not easy to pick 3, but for the purposes of this conversation, what would you say that those are?
I think
Well,
Jackie's already identified them.
I think so. I think certainly staffing is, I think, but staffing is one issue, and it's not only number, as I mentioned, but it is also about having a majority of full-time staff, and it's also about having a good mix of staff, that, you know, registered nurses and RPNs, registered practical nurses, and PSWs, of course, and a good team relationship between them. I also think food is a major issue. Food is one that we came across everywhere, and we went, and we had.
And we also ate everywhere we
Yes,
went.
I was going to say that. We tried, all of the members of our team tried all of the pureed diets, everything that was on offer for residents. Our researchers tried. So it was important. So we did a lot of firsthand. And the third, I would say, is probably the physical structure and organization, but there may be a few others vying for third. Pat, I'll turn it over to you.
Well, I mean, related to the staffing, are all of these questions about the conditions of work. which, as Jackie was saying earlier, having access to full-time employment or having permanent part-time employment for those people for whom part-time work works better at perhaps at particular times in their life. We were in a home in Western Canada where they didn't hire any agency persons, where more than 60% of their staff was full-time, which is in Ontario, it's like 47% for the most part. And all of the part-time jobs went to people who were their regular permanent part-timers. And so if someone was off on leave or for some other reason, they had someone who knew the residents and knew the rest of the staff who could come in there to work. And if a vacancy happened because someone retired or whatever, then they could call on these part-time people to fill those full-time positions. So, and one of the things we forget about in this part-time work and about what was exposed during COVID of so many of the staff having more than one place they worked in, was that we forget that that's not just about what it means for infection or from knowing the resident that Jackie talked about before, but it's also about knowing the place and the rest of the staff. When you bring in people that are only there for short periods of time, who don't know the place, that it makes a whole lot more work for the staff, and it really undermines teamwork. And if we're going to have staff that can respond to the individual needs and capacities of residents, they have to know the residents, as Jackie said, but they also have to know each other. And be able to have the power to respond to those needs. If you have to get everybody up at the table for 8 o'clock and you have 12 people you have to do that with, then your whole focus has to be on tasks and speed, and you don't have any time to respond to their individual needs. So the notion that these places are rigid places, they're rigid for the staff too. And if we're going to make them more flexible for the residents, we have to trust the staff. And what's central to that is them working in teams.
It's interesting. So knowing and recognizing that, and obviously you have published a tremendous amount of research around these issues and then themes over the course of your research work in the last number of years. Why is it that when we know these things, why is it that we haven't really taken the leap to put them in practice? And that's a huge question, I know. But what are the barriers? What are the barriers to putting some of these things in place?
Well, I think, and of course, Pat is the PI for our Reimagining Long-Term Care, but our proposal from the get-go talked about how long-term care has been considered a failure. A failure on the part of the individual for not keeping him or herself healthy, a failure on the part of the family for not stepping up to take care of their family members, a failure on the part of the system for not keeping someone healthy. And some of those assumptions have been a long time changing. Because we cannot do what we need to do within the sector with those problematic assumptions. Our strong belief, reaffirmed through our research, is long-term. We always will need long-term residential care. For reasons, so many reasons. I mean, the number of individuals we talked to for whom long-term care was a godsend because they were so lonely at home. The number of family members who can't live apart, another town, another city, who have two jobs themselves, who can't take care of their parent, who don't have the expertise because, again, of the complicated care that is often required. I mean, we need to realize, and I would say counter to some of the discussion that has gone on, that we need, and we will always need, long-term residential care. We need to make it what it needs to be to value and to provide the best possible space for our older Canadians.
I think there's also a whole thing about age in the dominant view in our society. All you have to do is watch television at night, and how many ads, the ones that aren't giving you a drug with all of their negative side effects, are ads to stay young. You can get wrinkles off your face. You can take this drug to make you be younger. That we certainly don't do much celebration of growing older, which is where we're all doing every day. And so I think that there's a whole thing, in addition to the failures that Jackie was talking about, is that I don't want to think about that. And we didn't meet very many people who planned to go into long-term care.
Mhm.
Yes.
But we also didn't meet very many people who wanted to even, who thought working there would be a good place to work.
Mhm.
Although many of them loved it. We did a study for the Ontario Nurses Association where one nurse we interviewed said that it was the last place she ever wanted to work, but she loves it now. She said she loves getting to know the families, getting to know the residents. When you're working in the hospital, as she did before, people are in and out. You barely get to know their names before they're gone. You have developed these relationships over time. But she also said, all my friends said, you'll lose all your skills. And she said, are you kidding? I use my entire range of skills every day in a way I never did when I worked in the hospital. But we have this kind of notion that this is just a place where we stick people, and that the only kind of care they need is something that any woman can do by virtue of being a woman, which is also not true. So that, and especially you're able to do that. It's one of the things you can do if you're a new immigrant or you're racialized. And it's just so obvious when you look at the kinds of pay and conditions that people get, that we fail to understand how skilled and important this work is. And until we change our mind on this, we used to say, is this a place where you would like your mother to come? Now we say, would you like to live here? And what would you like it to look like if you were going to live here? And get over yourself in saying it's never going to happen to me, because, that could be you even tomorrow, because there are a lot of younger people in long-term care now.
So have we started to reframe? Do you believe that COVID might have been the tipping point for starting to truly reframe this conversation? I see a little hemming and hawing, maybe, Pat, from you, because the narrative you're talking about is the narrative that I've been familiar with. It's like it's the place of last resort. It's a place where I don't want to go to work. It's a place where we really don't need to do very much. It's lifting and bathing, and that's about it. But the more I've studied the area, not studied from the context of what you would do, but certainly just gaining a stronger understanding of the sector and a little bit of my own experience in the home care sector, speaks to the fact that this is long-term is long-term. Complexities grow in the long-term care environment for many individuals living in those facilities. They don't usually lighten the load or the challenges, but reframing the importance of this care, especially as we're heading in the next decade, by 2031, 25% of our population will be over the age of 65. And that's not where I think we were thinking when we brought universal health care in many decades ago. The average age of Canadians back then was 27 years old. Now it's considerably higher. So what about that long-term reframing? What about that long-term vision?
I think that we're at a tipping point right now. We could go either way. As first of all, we have to remember that the majority of homes did not have COVID deaths. If you read the headlines, it sounds like all care in long-term care is horrible. All of it is like what the military reported, and that's what it's like all of the time, and it isn't. As Jackie was saying, we've been looking for places to go to look for good ideas worth sharing, as we like to say. We don't think that there's a single model out there because context counts, population counts, a whole lot of things out, but there are certainly good ideas that we can learn from. As Jackie also said, there's every time we have a crisis or some kind of scandal in long-term care, there's a yell to close them down and have everybody in home care. But for all of the reasons Jackie gave, that's not the solution either. And we forget that lots of homes are not havens in a heartless world. But in addition to that, what we forget is that congregate care can be good care, and we have seen good care. We asked a resident council not long ago here in the city of Toronto, actually, is there anything better about being here than being at home? And they unanimously said yes, yes. We feel safe. This might feel ironic in this time of COVID, but they felt. One example they gave us was a woman said, I had a stroke. I couldn't remember when to take my insulin or whether I'd taken my insulin. Here, they make sure I have my insulin. They said they had activities. They said, oh, I know we watch a lot of TV, but if I was home, there's only one thing I do, and that's watch TV. And here we have company. When we are at home, we would be all alone. So we have to start thinking about not only the positive aspects of congregate care, but also how we can make it as good as we can be. But I think we're at real risk right now in not only saying, well, the solution is home care, but also saying, oh, we fixed it because we have vaccines and people aren't dying from COVID anymore. Whereas, as Jackie so eloquently explained when we started out, this is just, we just saw the tip of what those problems are. So I'm afraid it will be, oh, well, let's go back to where we were, or there'll be promises for a nanosecond and we'll switch to seeing bridges as way more important to build than decent long-term care and decent working conditions for the people who work in long-term care. And the last thing I'd say in relation to that is, unless we do something about this, we're not going to have a long-term care labor force. The International Labor Organization, the Organization for Economic Cooperation and Development, the World Health Organization, all said before COVID, unless you do something about the conditions of work here, you're not going to have a labor force.
Yeah. So this begs me to ask the question. And I leave it open to whoever wants to jump in first. But we had a very, what would be, say, pointed announcement in the federal budget this week with respect to long-term care. Lots of detail, but the key things, the key takeaways were essentially the development of national standards and the investment of $3 billion of funding over the next 5 years to ensure those standards are met. I am absolutely curious what your perspective is on that budget announcement. So whoever would like to jump in first and answer.
Well, I'll just give an initial. I think it's a start. I think at least it's a discussion, but there's still, to quote the Center for Policy Alternatives, there's still a lot of heavy lifting to do here. It's short on detail, short on moving forward. And it does, very much the way in which it's set out, it is going to require federal provincial engagement. And so there is a lot of heavy lifting to do. Pat has, in some of her most recent work, has been working on these very issues. So I turn it over to Pat.
Well, is 5 billion a lot? It depends, right? It depends on the context. It depends on how it gets spent. It depends on what they're including. Are they including what they've already spent on PPE and other things? And it depends on where it goes. But it also depends on what the standards are. Like that, they have handed the standard over to the outfit that has been doing accreditation. Now they put a new person in charge, and they said they're going to restructure how they do those standards. So we'll see how that works. But I would say about what so far in terms of accreditation, it has not done the job. All of the homes in Quebec were accredited. And accreditation in Canada right now is most likely in the large for-profit places, because they have the organization to respond to the demands for data that requires, and to pay for the accreditation process. And the accreditation process has not resulted in the kinds of structural changes that we were talking about. Minimum staffing levels, continuing education, attention to the physical structures, attention to benefits and full-time jobs, and those kinds of things have not been at the center of what have been the standards set by accreditation. And they tend to be much more about clinical, as Jackie was saying earlier, than they are about the social. And the research I've seen on the consequences of accreditation in the past, the only thing I have seen that they did better on, the accredited places versus the non-accredited places, was in terms of the falls. Well, one of the things we've looked at in another study is this question about falls. And you do reduce the falls if you put everybody in a wheelchair, but that doesn't necessarily improve your quality of life. So as an indicator, I'm not convinced that it tells us much. So I'm concerned about the accreditation process. Maybe it'll work, and maybe it will, in fact. And they have said everything's open, but I sure hope what is open is ownership patterns, is, although I did hear the minister say she had a bias in favor of not-for-profit. Are they going to be open to establishing and enforcing minimum staffing levels? Are they going to say, don't contract out food and laundry and housekeeping, because we know that those are absolutely critical to care and can't be treated as ancillary services? Are they going to go in those directions or not? I mean, I think it's still an open question. I want to think that maybe it will be, and there's also the question about how long it's going to take. You know, the Ontario Long-Term Care Commission said, we don't need more studies. We need some action. And we didn't see a lot of action in the budget. We said, you know, we'll talk to folks, and we'll do this $5 billion over quite a long period of time. And, you know, by the 5 years from now, like when Ontario puts in its 4 hours of care, all of the people who are there right now are not going to be with us. Or very few of them are.
So it's a strong perspective. So what I potentially hear you saying is perhaps the government isn't listening to the right people. Who should government be listening to?
I think that they have listened. I think that they have said that it needs standards. I think that they have said that the money should be conditional. I think they have said there needs to be more money. So, but as Jackie said, the devil's, you know, we'll see. And will they do, when though it becomes obvious how much that costs, will they do that heavy lifting? So I have to be hopeful. And I'm glad there's something happening. But if the money goes down the drain and if it goes to profit, then we're not going to be a lot better off than we were before.
Yeah. So can you talk a little bit for those who are with us today who may not necessarily understand the high level difference between for-profit and not-for-profit structures in the sector? What are the fundamental differences in those two operating structures?
Well,
other than the obvious.
I think that, I mean, Jackie was talking about the history. The history has been, we've had 3 kinds of care delivery in long-term care for a long time: a private, not-for-profit, and government. And in the late 40s, because of scandals, the Ontario government, to use Ontario as an example, I know it isn't only people in Ontario, but they mandated every municipality to have what was then called a home for the aged, and those still exist. And then there are a lot of not-for-profit homes that are religious-based or community-based. They're owned by the Greek community or the Italian community or whatever. And then we have for-profit private homes. The big difference that took place after the Harris government changed the way they allocated beds. They greatly expanded beds, but they introduced a competitive bidding process that I would argue favored corporate ownership. And now that it's in this province, about 58% are corporate owned. We have the largest proportion in Canada, but every province has moved to some extent in that direction. So who cares? Well, I would argue who cares is that, well, and maybe Jackie can talk about the difference amongst them. But before I go there, one other thing, we should be clear that we're talking about nursing homes here, or what people mostly call nursing homes. We're talking about places provide 24-hour, 7-day-a-week nursing care that are heavily publicly subsidized and that are heavily regulated. But the big for-profits like Chartwell and Extendicare have a lot of retirement homes that are completely outside what we're talking about. They can charge you whatever they want. They are only lightly regulated, etc. So Jackie, why do we care?
Well, we care because research does indicate it makes a difference. There are differences in, for example, large for-profits. There are differences in mortality and morbidity. So differences in death rates and hospitalization rates. So complications. So there is a difference at the level of care. I would also suggest that there's an accountability tension there because these large for-profits are accountable to shareholders. So they are operating according to that expectation as well. So it isn't only about quality care that they need to be concerned. And certainly there have been some interesting reports lately around shareholders in the midst of all of this receiving bumps in pay in return. So I think we do care. And actually, I think the minister, when she was on Metro Morning, no, it wasn't Metro Morning, it was the Current, talking about the budget. She did speak about the vulnerability of this population and the fact that the vulnerability really doesn't jive well with this notion that it's a business, right? And it's a business for which shareholders seek returns. And this is the structure of the organization. I would say it's a problematic fit. In fact, I would suggest it doesn't fit. Now, complicating this issue, I'm sorry, Pat, this issue is the fact that some of our not-for-profits are contracting with for-profits to help manage their agencies. So there's a little bit of fuzziness going on that we are quite concerned about.
And that includes the contracting out of services like food and laundry, and because they're all private too, right? We were in one home where the food was contracted out, as was the actual delivery of the dietary work. And there were big signs in the dining room saying, "Don't talk to the dietary staff."
Wow.
Yeah.
That says an awful lot about that tension you've been speaking to. It doesn't seem, I mean, I guess I understand it to a certain degree, but it doesn't necessarily speak to the heart of caring for the resident at all, because that group of individuals is part of that circle of care. And cannot be part of the decoration of the environment in which that care is being delivered. speaks volumes around things. That leads me a little bit to my next question, which is a bit around future state, if you will. And oftentimes our conversations in the healthcare sector end up being binary in nature, all or nothing approaches to care, perhaps. For example, the concept of aging in place versus congregate care settings, or perhaps other kinds of binary conversations. Is a single strategy the right approach? And if it is, who leads that strategy? And if it's not, what do we do? How do we need to be looking at this?
Well, I'll start off by saying only if that single strategy is, we need to take account of context always and ensure that what we're doing and how we're structuring long-term care takes strong account of the differences in context. We would certainly say, and we have said that one size does not fit all. There are really important principles, we would argue, that need to be followed, but the way in which that plays out is different, and it depends on those strategies. Again, it's going back to one of the phrases that we use so much: the conditions of work are the conditions of care. That is a very important principle. We need to realize that we can't clamp down in a very unhealthy way on staff, giving them inadequate time to do what they need to do, and at the same time expect that we're going to have high quality care or really good relationships between staff and seniors in long-term residential care. So yes, and the other thing I will say is we're all aging in place. Our job, wherever that place is, our work is to ensure that we're provided the opportunity and the support to do it as well as we can.
I would add, we talk about standards rather than standardization, to pick up on what Jackie was saying about the context and the populations matter, right? I mean, if you say that our approach means that you hug everybody, well, one of the things we've heard is that, my religion would be opposed to that, right? And it's not that you can't learn something about human touch and human connection, but it doesn't necessarily have to take that form, right? To make care at the center, to go back to where we started, that it's a care relationship, and that relationship involves all those who work in, live in, and visit in long-term care, we would see, and those have to be taken into account. Do we need to blow it up and start all over again? I don't necessarily think so. And there's some interesting things from the past. I mean, we certainly should make sure that these places have proper ventilation, but it may well be the case that the places that were built in the 60s, before they introduced air conditioning, might have better ventilation because maybe they don't share the air throughout the whole building, right? So maybe there are things that we can learn from the past, or some of the homes that were built quite a while ago had things like auditoriums in them where the community could come in, and that there could be forms of entertainment, or cafeterias where people from the community could come in and eat, and where staff could eat, and where there could be some mixing. So there's some really quite good ideas and some interesting structures actually from the past that we can learn some from, and we've been building some interesting structures. And one of the things that we've talked about a lot is location. I've had a number of calls from smaller towns that whose municipal home is not going to fit the new regulations, and that what's being promoted is that you close that down and you move it out to the country. Well, we hear residents say, I don't want to be put out to pasture. I don't want to watch the grass grow. It's boring. I want to see people. I want to see action. I want to be. I want to be on Main Street. I don't want to be in the country. And the same with the families. I want to, now I can walk to where that home is, and I wouldn't be if you put it out there. The staff say, there's no public transit. How am I going to get there? So there's lots of things about the past that weren't terrible that we could keep, and that maybe we could figure out a way to structure those places. Turn the 4 bedrooms into two rooms, which is what they did in the Nordic countries to a large extent when they decided to go in that direction. They went all private rooms, but that to figure out, not, to be very cliched and old fashioned, throw the baby out with the bathwater, but figure out what's worth preserving without then going to as Jackie was saying, one single model. We can learn from them all, and they have some core principles they share that are well worth following through on, but you can apply those in different ways.
So what about that? Because you've had lots of experiences and learning from colleagues from the Nordic countries or others that you have worked with over time. What is the gold standard from your perspective in terms of care in the long-term setting from other places, so that we can learn not only from our own history, but also from other places that are doing things well? I don't think any system is ever perfect, but if you could assemble the perfect model from all of the places that you've looked at, what might be some of those lessons or physical constructs that may be things that we need to look at applying for our future?
Well, maybe. Oh,
no, go ahead, Pat.
I was just going to say my Nordic experience, which I always love to relate.
Yes.
That the nursing home was physically part of a building that had the town swimming pool, the town cinema, a daycare center, a spa, a cafeteria, and every resident had a room that had direct access to outside, and a small little kitchen thing where they could turn the power off if they had to, because that would be dangerous, or turn it back on when they had visitors or someone who could use it. But the real notion is the community coming together, and there are examples of that in another place we were in Ontario, where they combined the assisted living, the retirement home, and the long-term care home, and in ways that allowed them to do shared services of a similar sort. And they were in very close proximity. So, Jackie.
Well, and I think one of the other things we found in a number of places, Ontario, Nova Scotia, BC, and certainly and I'm going to talk more specifically about an example in Germany, where there is the agency, itself can be quite large, a couple of hundred or so beds, but having a unit, a living unit that they call within that, within which there were 10 to 12 residents, and they had a common area in which to eat, to cook, to engage in recreation and activities, and to visit, and their own separate bedrooms. So, but it was all within an area. That certainly seemed to be really successful. I can remember when I walked into this nursing home the first time in Germany, and it was just before supper time. And there was the what we would call the nurse, who was rolling pizza dough out for dinner. So the meal was cooked, the evening meal was cooked on site in the kitchen. She was rolling the pizza dough. 2 or 3 of the residents, and mind you, with dementia, were cutting with sharp knives peppers and onions and other vegetables to go on that pizza. Another one of the residents was emptying the dishwasher and setting the table, and yet another resident was pouring wine in preparation for the dinner. So it was such an amazing atmosphere. So the size of this unit, there were, I think in this case, there were 12 residents who shared this common space. allowed for this. There was a wonderful engagement between staff and residents. There was a wonderful engagement between residents, and there were the occasional family members who were also popping in to talk and visit. So a very different situation, very different scene, very different feel than long hallways of huge wards. So I guess our lesson here was the agency can be as large as possible. We're they sort of have but as long as there were these smaller units in which the primary engagement was taking place, it made such a difference.
So it sounds literally like a cluster of villages together, where there is activity. And I'd be curious to know what their outcomes on the metrics that they measure relative to resident health and longevity look like in an environment that actually deals with the social aspects and the mental wellness aspects of care.
We have some questions about the metrics in themselves, but even when we selected the places we went to, two in each country and in each province we visited. But with the way we selected them, we did look at the metrics, but that wasn't our primary way of selecting them. We went to the unions, we went to community organizations, and we went to policymakers saying, if you were looking for ideas worth sharing, promising practices, where would you go? And it is interesting in that we were only once sent to a privately owned place of all of the places we went. We didn't seek out, we didn't say we only want to go to publicly owned or a nonprofit, but that's how it ended up. That it's, to go back to what Jackie was saying about the size, it's another thing that we are hearing big time now, that they should be all small and home-like, but we saw home-like and big, and you can get economies of scale then, including like you can have a nurse practitioner for your home when it's of a size. You can't if it's tiny. You can have a big kitchen that provides you with all kinds of things. You can bring in entertainment. That you can have all kinds of services, and you can have a hairdresser, you can have a dentist, you can have other things in your building by designing the building, as Jackie says, with these little communities within them, rather than as a whole city. And then you can also locate it in urban areas, like,
It's fascinating. We're very close to the end of our hour. And I have one sort of wrap-up question that I'd like each of you to answer, because I know this is on the minds of the people who have joined us today, which is, when we talk about change and action, it takes that whole village to make that happen. So Jackie, if you were to tell people what is the one fundamental thing that they can do to help to push action forward, what would you say? And the same question to you, Pat, as well.
Well, I would say become familiar with the discussions. Become familiar with, there's so many wonderful organizations and agencies who are policy shops, as it were, who are preparing and releasing a lot of information around long-term care, and those of us doing research as well. But I would also, there's the government, your government officials. I would say connect with your government official and let them know, what your thoughts are, what you would like to see, what is important for you. I think going back to the issue that we have around some of the accountability regime that's going on is what gets counted isn't necessarily what counts. And so it's maybe not as important that everybody is out in a particular place by 8 o'clock for breakfast. Maybe it's more important that that individual get up at their own time and and start the day the way they want it to, and that there be the ability for them to get breakfast. Perhaps it's 9:30 or 10 o'clock in an environment that's familiar with them.
Pat?
Well, I would say almost the same, but I'd say is think about what you would like this care to look like and then go out and work for it.
Very well put. Pat and Jackie, I want to thank you so much for sharing your knowledge and your perspectives on such a critical and vital part of our healthcare system. I've learned a lot today, and I'm sure our audience has as well. And to our audience, thank you for joining us today. We will be sending out a link and a recording to this session in the coming days, and we would encourage you to watch this again because there was a lot that got covered in this conversation, and to please share it with your family and friends. We want to make sure that the information that we share with you is useful for the broader community and the networks that you have. So I also want to say to everyone, be sure to watch your email inbox for your next personal invitation to our next Health Hour Live. I won't give it away now in terms of what we were talking about, but however, like today's session, it will be one you will not want to miss. So again, Pat and Jackie, thank you so much for sharing your wisdom, your knowledge, and your insights with us today. I'm Leslie McGill, and thank you for joining Medical Alert's Health Hour Live today. Stay well, everyone. Take care.
And Leslie, could you put our website link up too? Thanks.
Absolutely.
Thanks,
Thank you.
Leslie.
Thank you so
Thanks
much.
very
Take
much.
care.
Bye-bye.
Bye-bye.